Very good evening, respected chairpersons and my dear friends. So, this is a very important topic on surgical skill transfer, because it is our moral duty to pass the skills, the surgical skills which we know to our residents or to of the trainee surgeons. So we all know that cataract surgery is the most commonly performed operation in the ophthalmology, and we try to teach the cataract surgery, try to pass the skills of cataract surgery to our residents, so that after their residency they can at least do cataract surgery in a better way. So surgical skill transfer from experienced surgeon to the resident is complicated by the fact that the teaching surgeon primarily acts as an observer rather than directly performing the procedure. So in the previous years when we were students, so we are either observing or assisting, or we are performing the surgical steps in supervision of our teachers, but our teachers were only the observers. So why there is SSTC? So there is a need of surgical skill transfer courses. So SSTC offers a systematic training platform for the surgeon in training, that is the trainee surgeons or the residents in cataract surgery and other subspecialties of the ophthalmology. So wet labs and dry labs in the form of simulator trainings are utilized to reduce the learning curve of the surgeon in training. It also establishes tissue awareness, dexterity and muscle memory required to perform each step of the procedure safely. Access to wet lab and simulator environment should be accomplished by establishing a surgical training curriculum in residency programs. So what are the challenges during the training? So there are several important factors which make training and learning cataract surgery challenges and the other surgical procedures for both the attending and the surgeon in training. Performance of successful intraocular surgery demands fine manual skills and in-depth knowledge of the ocular anatomy and a thorough understanding of each surgical principle, such as phaco-dynamics, which is the most commonly performed procedure these days. And there are no inconsequential steps in good surgery, and each step of the procedure relies on successful completion of the steps preceding it. So when we were students, so our teacher used to tell us that you master on one step, then go ahead with the other steps. While the resident surgeon is operating, the attending surgeon is primarily an observer with limited ability to intervene and prevent potentially visually devastating complications. In addition, now these days the patient expectations for a good surgical outcome are very high, and there are so many litigations, so many court cases pending in the courts. So these are the few studies done by various authors to assess the performance of the surgeon in training. So in one of the common study by the Rendelman et al., they observed that as the complication rate of cataract surgery, it reduces after the surgeon in training completes approximately 80 surgeries, 80 cataract surgeries. So when we were students, our teachers told us that you first observe 500 cases, then assist 100 cases, then perform one step 100 times each, then only after that you will be able to complete a cataract surgery case. Those were the days. Similarly, in another study, they found that the cataract surgery complication rate is reduced after 75 cases. So these are the few studies. Those were stressing that there is a need of a systematically planned surgical skill transfer courses. So few studies also suggest that complication rate of cataract surgery reduces for the training surgeons than the experienced surgeons, although after performing the surgeries in steps. 1 minute more here. So this is the program that we design in our institution, the wet labs. Now the stress is on competency based curriculum. Competency based surgical curriculum should include a structured wet lab and dry lab during the first year. So during the first year, the resident should know how to clinically examine the case and how to perform some portion of the senior resident cases and formatting feedback immediately after the cases, and like the few steps like capsulorhexis or irrigation aspiration practice that comes in first year and second year also. Now these days the technology is advancing. The virtually reality simulators, Dr. Titial sir told that the simulators play a very important role in surgical training. Use of simulator and surgical environment to practice the steps of phacoemulsification and VR surgeries. And these days few other simulators are available, like simulators for fundus examination, simulators for ROP screening, those are also available. So this simulator training should also be available for the resident training programs. So these are the few simulators. To conclude my talk, strategies for optimizing surgical education will continue to develop as residency program shift to SSTC and competency based programs, and also the simulator based training programs. The current body of literature suggests that residents can safely learn ophthalmic surgery using a number of different instructional techniques and curriculums. But an organized, systematic approach to surgical education will offer the greatest ability to identify and utilize the evidence-based best practices. So more investigations are needed to understand how the best tailor and instructional approach to the learner to maximize the patient safety and effective skill transfer should be advocated. New advancements in the surgical education such as simulators will be beneficial to the patients, new surgery trainees and experienced surgeons acquiring new skills as the field evolves, although the cost of this technology is very high. So thank you very much for your patience hearing.